Hello and welcome to Below the Hospital. I'm your host, Garland-Rhea Grisby Sr., Sterile Processing Manager at Sutter Health, CPMC. In this podcast, I ask what some folks might consider hard questions, but what I think are informative questions about the sterile processing profession. I would like to welcome to the show someone whom I've known for quite a few years now. We have Daniel Lightfoot. Daniel, welcome to the show.
Yeah, welcome, Garland.
So, just a little background about Daniel. Daniel is Director of Medical Affairs for the Americas at Nanosonics. He has an extensive experience in cell and microbiology, has contributed to the development of AMI documents such as ST98 and ST108, and holds a PhD from Karolinska Institute in Stockholm. And I've had the pleasure of working with Daniel on a few of those AMI projects, and it is a pleasure to have him on this show.
It's exciting to be here. Thanks, you, Garland.
So let's just dive right into it, right? HSPA just happened. So tell me about the research you just presented at HSPA and what was the problem that you were solving and what were some of the patient safety failures that prompted this study?
Well, what's interesting is it's been about 9 years in research, and we've been trying to understand what it is about endoscopes, flexible endoscopes, that make it continuously linked to infections and outbreaks. And we are aware that obviously if there's a failing in a process, that could lead to colonization of a scope, and that could lead to exposure and infection of a patient. But there are also many published cases where everything was fine. There's nothing wrong with the scope. Processing was done to IFUs with skilled SPD staff, and yet infection still occurred. And so we really looked at endoscopes and tried to understand the problem. And it turns out it's biofilm. It's not only biofilm in the suction biopsy, the working channel of endoscope, but it's biofilm through all internal channels. And biofilm is resistant to cleaning, and it's the natural state of microorganisms. People think that biofilm is something specific, but there is a type of biofilm that's specific to endoscopes, and that's cyclic buildup biofilm. And this was another discovery by another scientist, Michelle Alpha. And so we partnered with her to really understand, how do we remove biofilm in endoscopes? And what makes biofilm endoscopes unique is that they are not in an aqueous hydrated state, which is what our biofilm models currently use. And this is the biofilm that you see in sinks, you see in fish tanks and pools, on rocks and streams. It's very soft, very fluffy, it's easy to remove. But what we find in endoscopes is a hardened, encrusted biofilm. And this is because it's going through cycles of hydration, drying, as well as exposure to aldehydes. Now, aldehydes are your GTAs, OPAs. It's what we rely on in our AERs, many AERs, to do our disinfection, but it's actually contributing to the problem. And this was a big discovery on our part. And if you consider aldehydes like formaldehyde, something we're all familiar with in school, at some point you took a worm or a cricket or a frog out of a vat, and it looked fairly new or fresh, but these organisms could be many, many years old. The reason why is they were fixed. Aldehydes work by binding organic molecules together and holding it in place. And that's how it works as a sterilant. It kills organisms by stopping all cellular activity. It's not removing it, it's stopping it. So it's kind of like a snapshot. It freezes it in place. Well, it's doing the same thing to organic material inside of endoscopes. It's freezing it in place, as well as freezing it and adhering it to the inside surfaces of the lumen. And this makes it really hard. So the very chemistries we are relying on to provide disinfection are contributing to the problem of biofilm formation and its hardening and adherence. And so we spent 9 years trying to understand how to remove it. And it's been a toil, but we came to a solution, and this is part of what I presented at HSPA.
Wow, it was a lot there. It was a lot there,
Yes.
folks. So thus you see Daniel's knowledge in cell and microbiology. And this is truly important because scopes have been getting processed for years, right? And the things that we think are helpful, we never believe that, hey, this may be contributing to an issue later on down the line. As you heard, 9 years of studies, 9 years, and I just had an interview and we talked about the data that goes into these reports that come out and the studies that come out, and they're just not overnight studies. So thank you for giving us that info on what you presented and why you presented it. So that being said, why is it that endoscope infections are likely underestimated?
Well, I think it's two big reasons. One of them is time, which is a fundamental concept behind biology, and the other one is what we're paying attention to. And so with time, what we call attack rate in epidemiology is when you see when someone's exposed. Well, you have the paradigm of infection, so that's exposure, contraction, it enters the organism, and then expression. You can see a physical change, a phenotypic change. So what we do in the medical field is if we're exposed to something, or a patient's exposed to something, we see an infection really close in time, like a few days. We intellectually linked these two together and said, hey, maybe it was the procedure I performed the other day or a few days ago that contributed to that infection. But what we've learned is colonization can last for months, even years. And so there have been published studies that I highlighted in the HSPA conference, is that people were exposed, and through whole genome sequencing, that's the only tool that truly can link all these together. Shows that a patient was exposed, but they remained colonized for over a year before they were ill. And so this prolonged attack rate is what we really need to pay attention to. So this is the true attack rate. So we're only paying attention to the acute, but not the protracted. We do really good as a community when it comes to MDROs, or organisms that we really pay attention to, the really nasty pathogenic ones. And we will track these down. We'll do, as soon as an outbreak happens, we'll trace it. We'll do all these mitigating factors to stop the spread. But there's a lot of other organisms that are less pathogenic, that might not be drug resistant, that we rely on pharmaceuticals to address, or they are not so lethal or pathogenically harmful to the patient, but it creates a state of dysbiosis. And dysbiosis can lead and weaken you to further secondary infections. So when we talk about colonization, we only pay attention to the most lethal or most pathogenic organisms, but we're not paying attention to the lesser or non-pathogenic, which can lead to secondary infections. And so for that, I think that it's fairly largely underestimated.
We are getting a lot of information that we might not otherwise know about, right? And you're right. Over the years, folks have you know targeted those main things that we've seen. Oh, we got to deal with this, we got to deal with that, but it's deeper than that, clearly. So can you walk me through the study's design?
Yeah, so what we did is we tested it, we pursued a technology to help remove biofilm. And we realized that flushing doesn't work. Flushing is just running a chemistry over biofilm, but if it's hardened and encrusted, it's only affecting the surface. It's not affecting any of the organisms below it. And so the biofilm persists and even grows. And so what we understood is that you really need a physical action to abrase it, to remove it. What you do with brushing, internal brushing, but that's only affecting your working channels. So what about all the other channels that we're relying on flushing? If you take a common colonoscope, we're only brushing less than 1/3 of the internal surface. And we're relying over 2/3 to be flushed and calling that clean and then going to disinfection. So what we did is we took endoscopes, lumen, and we encrusted it with what we call artificial test soil. It's a blood-based solution. It mimics organic matter. And we ran it through endoscopes for 18 hours. And then we rinsed it. We ran glutaldehyde through it. And then we dried it. And then we set it there overnight to simulate a dirty endoscope. Then we went back the next day. We ran ATS through it, ran GTS through it, glutaldehyde through it, flushed it, air dried it, and then let it sit overnight. Then we went back the next day, and we did this for 5 days in a row because we really wanted to make it tough. And so this is a very, very contaminated endoscope. And then we tested this versus flushing and brushing, what we're doing now as a community, and this new technology, and which one remove the biofilm better. And with this new technology that we debuted, it has a proprietary method of action. It has a cleaning agent that goes through that's non-toxic, and it can remove biofilm to near disinfection levels. So disinfection levels is 0. And so we're getting that in all lumen, all channels. And so we're really excited, and it's why we debuted it at HSPA.
I'm sure all of us in the scope world, those that are touching scopes or cleaning scopes, I know sometimes it keeps us up at night, but yes, I'm sure we would all love something that would get close to disinfecting in the cleaning phase. So now you touched on some of the findings, but what were your major findings, and did you discover anything unexpected? I know you've seen a lot.
I think over this 9 years, I think some of the big things that we understood was what flushing is actually doing. Now, our SBD professionals do a great job on reprocessing endoscopes. And with the brushing channel, by and large, it's doing a great job. But what you can't do is really clean those hard to reach areas inside the housing, inside these lumen. And that's where we found most of the trouble is, most of the biofilm is in these channels. And so how do you remove them? And we found out also that, flushing doesn't work. There's this mathematical equation called the Hagen-Poiseuille equation. And it just basically describes fluidic flow, the dynamics of fluidic flow. And so we've all experienced this as a kid where your parents give you a shake and they give you a really narrow straw. You can't hear the shake and you look at your parent and you have to go grab a bigger straw. Well, that's showing fluidic pressure that you needed, that this small restriction in diameter is restricting flow. And so when we apply water and detergent down a scope, most of it's going down the biopsy channel. And only a few tablespoons are actually going down each of the other channels. So we're relying on this entire length, which can be over a meter, and we're allowing a few tablespoons of detergent to provide full cleaning of an endoscope. Well, that's not doing it. And then we also learned about aldehydes, on how it's cross-linking not only organic matter together, it's providing a shell of protection to the organisms, as well as adhering it to the surface of the lumen endoscope. So this was really challenging. And so we had to find a way. We tried many detergents. We tried sterilants, detergents, disinfectants, combinations of thereof, and we just couldn't find anything that removed it. And so what we had to do, and this was the epiphany of the whole project, we had basically 6-7 years of failure. And then we came to the idea that what we need is a solid that moves like a liquid down all these small channels and all these curvatures. And that's what we invented.
Love the illustration about the straw. I'm sure we can. I'm sure we can. You painted the picture for us, right? Especially for folks who have absolutely no idea what you're talking about. But that straw illustration was interesting. And then what was great to hear is some folks don't really like to talk about the failures, right? But you said no. We had this many years of failures, and so this is what we had to do because of it. So talking about cleaning biofilm, what are the limits of manual cleaning? You touched on it, but what are the limits of manual cleaning as it relates to biofilm?
It's like anything manual, it's the user. I mean, you can be exceptional at a manual process, and maybe the next guy isn't so much. So yeah, we probably all met them at some point in our career. And that's where automation really plays in. That's why automation is such a big topic in our AAMI standards meetings, is because if we can create something that's automated through device innovations, that's reliable, repeatable, that meets the standards, then that removes that variability of human nature. And we're all guilty of this. I mean, we're tired one day, we're busy one day, somebody makes us mad, you're getting yelled at, and then you're told to perform at the same expert level, and we don't as humans. We have variability. And so removing that human element, it's not a question of how skilled you are or how smart you are. And the SBD community, very highly credentialed, very skilled. We have our days, And then we also have that new guy that comes in that we got to not only do what we're doing, but keep an eye on them. And so because of this variability, it creates a challenge. And look at how well AERs had changed our community and our daily lives compared to and it's been phenomenal. It's automated, it's repeatable, reproducible, and it's a great tool. Now we're focusing on the cleaning, because if cleaning isn't done well, then disinfection isn't achieved. And so that's where we spent our time, because if the biofilm is removed, it goes to the AERs or it goes through a sterilization process, and it's hardening and cementing that biofilm in there. It's not killing it, it's not removing it, it's killing some of it, not all of it. And so that's the problem.
Wow. So yeah, that you talked about it, human factors, right? And it's not a limit. And some folks get frightened when they talk about technology and automation, right? They think, oh my God, we're going to lose our jobs. No, it's not about that. It's actually making sure that what might have not got properly cleaned is cleaned consistently the same way every day. Like you mentioned, yeah, we have our days. All of us, we as human beings, like I say, you are working at 100% one day, 100% the next day, 20% the next day, for whatever reason. So, thanks for sharing that. Now, as an SPD professional, what are the immediate implications for folks like me, like healthcare leaders or technicians who handle soiled instruments on a daily basis?
Like anything else, this community, when I first was exposed to this community in AME, is just astounding. And I'm a scientist, and you guys take a very scientific approach to everything, and that was very refreshing and obviously very familiar with me, and I'm very appreciative of it. And when I also look at how much demand is on this community, how much you have to get done in a day, and the best comment I heard, I was at an HSPA conference a few years ago, and the comment was, without SPD, you don't have a hospital. And that was profound. And so what we need to do as communities, how do we support SPD professionals? How do we provide them the right tools? I mean, if you give a surgeon a hacksaw from Home Depot, that's not helping. But if you give them, a right scalpel, that is. And so that's the intent of the medical device industry, is to provide the right tools, the right instruments for the SPD professionals. Not replace them. We need you. We don't have a hospital without you. And so for that day-to-day, companies spend time looking at it. I spend a lot of time talking to SPD professionals, going into different environments, seeing it, and find out how we can improve. And the better tools we give you, the better you protect our patients, the better a hospital it is, the better our healthcare is, and profoundly, and the end result is, the safer it is for our patients.
Thank you. There you have it. And thanks for the for whoever made that quote. Bravo, right? Whoever told you that quote, that was great, because it's so true. It's so true. I was interviewing someone and I was telling them about an experience where the physicians actually came down to um, my department, and they had no idea of all of the work that went into it, and they had a better and greater appreciation for SPD once they actually saw what all went into the things that they need. So that was a plus. So, are there any alterations to SPD operations that might be merited based on the findings in your study?
I think it's what we're seeing being published right now is lots of studies, and whole genome sequencing is opening a lens to what we're doing, because we're seeing this longer protracted attack rate. And I think that's going to bring a lot of insights, and it might bring changes, good changes, to how we do things, not just in SPD, but as a hospital and in healthcare community, because we are trying to reduce infections, but there are infections that occur months, years afterwards, as I mentioned earlier. Second is, how do we provide efficiencies? How do we provide things that are going to improve what SPD staff do and what we do in a hospital? And there's just a lot of work. We're also, as new technologies come in, we have to question them. We have to sit there and test. Just because it's new doesn't mean it's good. And we have to see, does this meet our standards? Are there, one great thing I love about SPD is their ability to, and their desire to test everything. So they sit there and they say, no, I'm not going to trust that this worked. I want to test it. You know, we use CIs and BIs and sterilizers every time for this very reason. Like, I don't trust the machine. And you shouldn't. You know, we lie on them, but we should always be a bit skeptical, and we should always be testing things, because you guys are the gateway. You guys are judging all the instruments that leave. It comes into your hands, and then when it leaves, people are expecting it to be fine, to be okay, to be right next for use. And you guys are the gatekeepers for that. This whole community, it's a profound, and I think everybody thinks it's underrated part of industry, but it's kind of like a race car driver. They rely on the engineers to design the engineer and design the engine in the car. And if they don't do it right, your car is not good. It's not competitive.
Well, Daniel, thank you. I just want to thank you and our listeners. I'm sure they want to thank you for giving us this condensed version of the importance of what we actually do and the testing and that goes into the technology that we have, finding issues that we otherwise wouldn't see, as far as not just endoscopes but surgical instruments in its entirety. So want to thank you and the folks that you've worked with to come up with this data, and we thank you for joining the show. We know you're a busy man, um, but want to thank you for taking the time out.
No, it's been fantastic. Thank you, Garland. I'm a big fan of Amy, because one of the brilliant things that Amy does is it's industry to bedside. And it brings all the stakeholders together, and they say, well, we got problems. We want to do improvements. So we start from the very beginning, and you start all the way down the patient. And then another fantastic thing is along the entire walkway. I mean, these standards take a long time, as you know, to get through, but the FDA is at the table. And so when we do produce a document, it's usually in a good place, and then it gets refined. And it creates great guidance for all of us. So big fan of Amy for that.
And many years ago, when I first stepped foot in the Amy meeting, when I saw the FDA there, I was blown away. I was like, wow, okay, great. Representation all across the board. So,
yes.
Yeah. Well, folks, as usual, I hope this episode has been useful. We'll be back in 2 weeks with another episode. If you want to support the podcast, you can find us at Below the Hospital on Spotify, Apple Podcast, YouTube, and amy.org. Until then, see you when I see you.